to Charlotte, North Carolina, where she worked in acute care for over 3 years. She now leads the Inpatient Physical Therapy Initiative in post-COVID care. Dr. McCormick received her Doctor of Physical Therapy from the University of Rhode Island. She's a board-certified neurologic physical therapist, as well as a certified brain injury specialist and certified in LSVT big therapy. She leads the Outpatient Neurologic Physical Therapy Department at St. Luke's University Health Network. And Dr. McCormick believes in encouraging patients to focus their efforts during treatment sessions to reach their personal long-term goals. So again, as usual, make sure that you complete the quiz and the course evaluation in my e-learning in order to get credit, CE credit for this course. And without further ado, I will turn this over to Dr. Collins.
Okay. Good morning, everyone. I'm Lauren Collins. I've been working on the COVID-19 mobility team at St. Luke's Bethlehem for the past 8 months. I'm going to go through the course objectives and disclosures first. Oh, there we go. Okay. So this is the continuing medical education credit information. My designation statement, if you want to read through that. We have no disclosures. And our learning objectives. So the participants will be able to analyze the evolving treatment guidelines for management of acutely ill coronavirus patients. Participants will be able to describe at least 2 different treatment ideas for an acute low-functioning coronavirus patient. And given a case example with examination data, participants will be able to prescribe appropriate aerobic exercise intensity, duration, and frequency, and participants will be able to identify appropriate outcome measures to implement for post-acute COVID patients. So I'm going to go over a brief overview of COVID. There have been over 10 million cases now in the United States and over 200,000 deaths since January of 2020. Coronavirus is known to have a long incubation period, and symptoms can appear 2 to 14 days after exposure to the virus. The most common symptoms are fever, cough, and fatigue, ranging from completely asymptomatic to severe illness and acute respiratory failure. The virus starts in the nose and the mouth and works its way down to the alveoli where gas exchange occurs. The virus itself has an S protein that covers the coronavirus, and it links to ACE2 receptors on the cell wall of the alveoli. This allows the virus to enter the RNA cells, and it's replicated within the host cell, and the host cell then dies, and new coronaviruses infect the neighboring cells, which destroys the respiratory system. Inflammation can be excessive, contributing to damage to the lung tissue, and they commonly have fluid accumulation, decreased oxygen exchange, and alveolar collapse. According to the CDC, older adults who have severe underlying medical conditions like heart or lung disease and diabetes seem to be at a higher risk for developing more serious complications from the COVID-19 illness. So the clinical presentation, we know COVID to mostly impact the pulmonary system, and the lung damage from COVID-19 leads to an impairment in gas exchange, with potential impairment for pulmonary function. As a result, many of these patients experience dyspnea and tachypnea, which is more prevalent on exertion, and this may or may not correlate to the degree of hypoxia. The cardiac system is also impacted. Tachycardia is present in almost all patients in acute care, and there's commonly new arrhythmias associated. According to this study by Yonter et al., acutely 36% with COVID-19 developed neurologic system impairments, including headaches, altered consciousness, seizures, absence of smell and taste, paresthesias, and stroke. And sometimes the acute cognitive impairment secondary to the hypoxia can result in a long-term cognitive impairment. The hematologic system is also impacted. You often see hypercoagulability associated with COVID, resulting in DVT and PEs, MIs. And there's, of course, functional impairments associated with ICU-acquired weakness. So St. Luke's developed an algorithm to classify patients based on their symptoms and their oxygenation levels. You see here the mild stage has viral symptoms and no shortness of breath and 0 to 3 liters per minute of oxygen. The moderate stage has viral symptoms and shortness of breath, and they're on 4 to 15 liters of oxygen. Severe has viral symptoms and severe shortness of breath, and they're usually on high flow nasal cannula. And then very severe is respiratory failure or shock, and these patients are intubated. A PT consult and evaluation is included in the protocol in the mild and moderate and severe stages, just not in the very severe stage. Self-proning is encouraged if the patients are able to. In the moderate and severe stages for 12 to 16 hours is what is recommended. And according to the Surviving Sepsis Campaign panel of experts recommendations, these patients should have, the ventilated patients should have a high PEEP to avoid the opening and closing of the alveoli and a low tidal volume, and their oxygen saturation shouldn't be higher than 96%. The high PEEP also increases and sustains the alveolar recruitment, which improves oxygen and reduces oxygen requirements. A lot of these patients are frequently fluctuating between the different stages, so providers have to consider all of their symptoms in order to pick a protocol. And each category has an associated medical protocol. So I'm going to give a brief overview of the medical treatment protocol at St. Luke's. If you're interested in the full treatment protocol, you can find information on the St. Luke's COVID-19 website, or you can feel free to email me and I can send that over to you. So remdesivir is an antiviral that we've heard a lot about in the news. This is given in the mild and moderate stages, as well as dexamethasone, the steroid. In the mild stage, the patients receive dexamethasone and remdesivir only if they're on oxygen. If they're not on oxygen but have positive symptoms or high risk, such as older than 65, obesity, or immunocompromised, then they will receive remdesivir and be considered for plasma therapy. The dexamethasone steroid is administered via IV for 10 days. If the patient's discharged prior to then they'll go home with the equivalent on a prednisone course. Then convalescent plasma, which is using another person's blood to take the antibodies against COVID-19, someone who's been infected already, is considered in all stages based on EUA guidance. And EUA guidance is emergency use authorization, which is the authority granted by the FDA. Anticoagulation is present in all these patients. If they don't have a DVT or a PE and their D-dimer is less than 2.5, then they're given Lovenox or heparin during their hospital stay. The dose is based off of their BMI. And when they leave, all patients are given Eliquis for 30 days upon discharge. Okay. So prone positioning can result in an increase in oxygenation due to improved ventilation and perfusion matching in the prone position, because the dorsal areas of the lungs are no longer compressed by the weight of the abdominal cavity and the mediastinum. allowing the dorsal areas to reopen and leading to recruitment of more efficient gas exchange. For patients intubated and sedated, a team of 4 to 6 members is required to safely prone a patient with significant prep time for positioning of pillows and extra padding in areas that are prone to pressure. And this also requires frequent positional changes of their head and their arms in these intubated patients. This helps reduce the chance of any kind of brachial plexus injury in the arms. And then in functional patients, you want to encourage side lying to prone, side lying on the other side, sitting upright at the edge of the bed or up in a chair. And these positional changes should be performed every 30 to 120 minutes. Education is key for these independent mobile patients that have these purely oxygenation difficulties so that they can self-mobilize and open various areas of the lungs. So many of our acute and outpatient PTOT teammates were trained to be part of a proning team when this first started. We were utilized in the ICU and also on the floors to help teach patients different positions to be in. It was found to be very helpful. So for acute PT treatment, we want to do things that other providers can't. None of these patients were allowed visitors. They are relying solely on staff members for orientation, stress management, and comfort. Diaries can assist with anxiety and depression management, including writing down phone numbers so that they can talk to their family members. Many of them didn't have cell phones, so teaching them how to use the hospital phone. We also want to teach the Dyspnea Scale for them to go home in relation to their heart rate and oxygen response. And that 0 to 10 scale is easiest for patients to remember and can be practiced in the room as they approach discharge. And Betsy will talk a little bit more about how this relates to patients and outpatient as well. So some studies recommended using the active cycle of breathing technique, which consists of 3 main phases: breath control, breathing exercises and thoracic expansion, huffing, or forced expiration techniques. This has the potential of generating airborne particles or respiratory droplets, and these are also known as AGPs, or aerosol generating procedures. They include huffing, coughing, oscillating devices that produce coughing, and intubation and extubation is also an aerosol generating procedure. So although these active cycle of breathing techniques and huffing and coughing techniques are frequently utilized in patients with respiratory impairments, they shouldn't necessarily be your first choice of treatment for patients with COVID-19 to avoid excess production of airborne particles in the room. So other precautions according to the Journal of Physiotherapy Recommendations Guide that was released in March of 2020 include utilizing airborne precautions for all COVID-19 patients when possible, which is what we do. But you can also ask them to wear a mask when you're in the room to help reduce your exposure to those particles in the air. And a negative pressure room should be utilized for any aerosol generating procedures. Screening should be performed in communication with the interdisciplinary team to reduce the amount of teammates exposed to the virus. They also recommend workforce planning, so allowing additional shifts for part-time staff, flexible coverage to accommodate for PPE, and later shifts for proning. They also recommended organizing your staff into teams, which is part of what we did at St. Luke's Bethlehem. We had designated staff to see these COVID-19 patients, which reduces the amount of PPE that's being utilized and also the exposure throughout the team. You also want to encourage psychosocial support for these teammates that are treating COVID-19 patients for their heightened anxiety levels during the difficult time. And early mobilization should be carefully considered based on the patient's state. So bed mobility, sitting balance, sit to stand, standing balance, and upper or lower body ergometry was considered in some of the other studies, if you have the availability of cleaning products, an appropriate protocol to clean those things in and out of the room. And then active range of motion exercises to maintain or improve joint integrity. So other things to consider in your treatment in acute care are psychosocial issues such as depression, ICU psychosis, or anxiety. These patients have an impaired mobility to reintegrate into the community post-recovery. They also experience delirium from pain medications and sedatives. And in order to manage that, you want to think about early mobility, proper lighting within the room, opening and closing the blinds during the day and at night, and then minimize the amount or change in staff within the room. So consistency of nursing staff is very helpful for these patients and rehab staff from day to day. You also want to consider that this may not be a ventilation issue, it could be a perfusion issue. So to improve perfusion, you want to find a posture that gets them improved perfusion for exercise to occur if they're easily desaturating. So laying on their side to do exercises, or proning and teaching them exercises, whether it's breathing exercises or active range of motion exercises. And one position that I learned during my research was quadruped, which can only really be used in your younger, more active patients. But this gives an opportunity for the lungs to expand throughout all of their ability, and can really improve secretion management for patients with a lot of secretions. Okay, so at Bethlehem, we started a mobility action plan in April, and our plan consisted of daily communication with the restorative therapy team, occupational therapy, and physical therapy. And each day between the three disciplines, we addressed every COVID-19 patient to the best of our ability. It consisted of rounding with nursing providers to determine new appropriate PT consults for those that were improving. We also frequently communicated with respiratory therapy on oxygen titration and case management in regards to discharge disposition, family support, and DME. Our goal was to maintain or improve functional mobility to prepare for a safe discharge home. The team faced multiple barriers to discharge, including limited COVID beds in rehab facilities, surges from skilled nursing facilities, with limited availability to be able to take these COVID positive patients back due to resources and staffing and PPE. And some of the barriers to discharge home included family safety and the ability for the patient to self-isolate in one room or on one floor of the home. So the way we tracked our measures was using the Bmat, which is actually a nursing tool. So we were tracking progress based on how nursing scored them and the Bmat. The level 1 for the Bmat is a sit and shake. The patient sits on the side of the bed and they shake across midline the nurse's hand. The second level is to extend their knee and dorsiflex and plantar flex their foot. And level 3 is to stand, and they should be able to hold that for a count of 5 seconds. And then the fourth level is walking. So they stand and march in place first, and then they take a step forward and back, and hopefully progress to ambulation within the room. I'm going to orient you to the graphs that I'll be using in the next couple of slides. This is our Bmat tracker tool, and this was all admissions and all dispositions within St. Luke's, and these are only COVID positive patients. So the green is the total Bmat improvements, this line here. The red is Bmat total flats, meaning they didn't increase or decrease in their level, and the orange is declines. On the left, you'll see the total number, and on the bottom, it's from April to August, our tracking. And this is cases just at Bethlehem. So in April 2020, we initiated our mobility program, and there was an increase in coordination with inpatient rehab and the restorative and nursing team. This resulted in an increased rate of improvements during the height of COVID admissions, as you can see here. Less declines in Bmat scores, and an increase in flats with Bmat scores, which, given their medical condition changes, is helpful in our goal of discharge home. So in total, 65.4% of the Bmat encounters improved or remained consistent with mobility upon admission, and 32.5% declined. This is just P8, which is where the majority of our COVID-19 patients with mild and moderate cases were held. Those are more mobile patients typically. There's a continuous incline in the number of improved Bmat scores in April, but a notable decrease here in the declines. And then we talked about the importance of our discharge disposition. We wanted these patients to go home if they were able to. These are patients that were admitted from home and discharged to home. There's a sharp decrease in the Bmat declines once that mobility program is initiated, which was pretty awesome to see. And then these are patients that were admitted from home and discharged to a facility. These patients still had functional improvements during their course of their hospital stay, and other factors could have been contributing to their discharge disposition. Like I talked about before, maybe not being able to self-isolate at home or having the support at home. And these patients, the flats increased in April, and the declines remain similar, with a sharp rise in the improved scores. And in June here, you'll see a decline in the improvements, and we had a surge of patients that were admitted from an assisted living dementia unit, and that's impacting their scores. They weren't able to carry over or really participate with us, and they were in an unfamiliar environment. A lot of them, unfortunately, ended up restrained because they weren't able to stay safely in the bed. And then these are patients admitted from a facility, discharged to a facility. It's encouraging to still see this increase in improvement in Bmat scores, especially for the facilities, to see that the patient's functional improvements occurred prior to them discharging back to the facility rather than initiating the mobility once they return back to the facility. So all in all, we had 119 out of 171 patients admitted from home that returned home, 70%, and 52 out of 171 patients admitted from home that were discharged to a facility, 30%. We had greater than 95% compliance with our daily intervention for patients with COVID-19, meaning that one of those disciplines addressed the COVID patient every day, Monday through Friday. And we saw improved communication and carryover with the nursing staff. Pretty cool to see these Bmat improvements despite our staffing reductions and our workflow changes and PPE requirements. And now we'll go into a case study. This is a 72-year-old female admitted from home to St. Luke's Bethlehem with acute respiratory failure, positive COVID-19, past medical history of coronary artery disease, hypertension, obesity. She was intubated on arrival, 5/2, and extubated on 5/5. She received remdesivir and convalescent plasma. She was independent at baseline with the occasional use of a straight cane, resides in a 1-level home with 3 steps to enter. She was transferred from ICU to the floor on 10 liters of oxygen and found to have a new small right cerebellar CVA. Patient was able to sit edge of bed and briefly stand with PT in the ICU, but desaturated to 83% on 15 liters. So how would you safely progress this patient? First of all, you want to improve her sitting balance and her sitting tolerance to greater than 5 minutes, maintaining her stable vitals on whatever oxygen she's on. We would coordinate with nursing and respiratory to see how her respiratory status was overnight and what they think may be the best time for treatment today. You want to work on standing and bed to chair transfers and to tolerate that. Encourage them to do that with nursing 3 times a day. And then progress to ambulation within the room. What are some treatment ideas when you're unable to tolerate functional mobility in ambulation? You want to consider proning education for this patient, breath control techniques, sit to stand, upper extremity movements for rib expansion, and maybe some reaching tasks to work on grasp and fine motor coordination. And then is home a realistic discharge option? In this patient, we're mostly concerned about her pulmonary function and the amount of oxygen that she's on. So if she's able to maintain her oxygen levels with ambulation, she may be able to discharge home. Her stroke was a small stroke with mild coordination impairments in the left upper extremity primarily. She has a supportive spouse and a good home setup. So depending on her ambulation tolerance and level of reliance on her caregiver, she may be able to self-isolate at home. But if she still requires physical assistance with functional mobility, it may be difficult to discharge her home if she's unable to self-isolate. All right, now we're going to move on to outpatient rehab, and I'll turn you over to Betsy.
Great, thanks, Lauren. Yeah, so we're gonna switch over to outpatient therapy, and I want to just say, like, we're skipping a little bit of the continuum of care in acute rehab and skilled nursing and home care before these patients might actually make it to an outpatient clinic. So thanks to all of our friends that have been helping triage in the in-between points, but also a lot of patients might just see you straight to outpatient because they never ended up in the hospital. So kind of seeing people all over the map as far as that goes. I put this graphic up about the fun begins where the pavement ends, because I feel like with this diagnosis, it's we're seeing patients that we don't have established practice patterns for, we don't have a whole lot of research behind, because it's all new. So we're off the beaten path now, and it's kind of exciting. So outpatient management, just kind of like Lauren had been saying, there's a huge amount of body systems that could be affected by COVID. So the initial thing that everybody thinks of is pulmonary, for good reason. You hear about people on ventilators, and that's why people are dying, is mostly because they're not getting, oxygen saturated to their brains. And but there's also people are having MIs, they're having gastrointestinal difficulties, renal failure, a lot of neurologic involvement, so strokes, peripheral nervous systems are affected as well with polyneuropathies, some cranial nerve neuritises, so we're seeing some vestibular neuritises, some ophthalmoplegias, and hematologic system also involved. So people are having DVTs, and these are all impairments that we might see in the outpatient system to be prepared for. And so it's not just the primary involvement there, but also the secondary effects of possibly having been in the ICU and sitting in a hospital bed for days on a ventilator. And something that we're kind of more familiar with from other diagnoses is post-intensive care syndrome. And that might be secondary effects that we're dealing with in an outpatient setting as well. So because somebody could have been ventilated for a while, it could be affecting their voice and swallowing. Neurocognitive deficits could be seen outside of just if they had a stroke and there was any sort of brain injury involved just from having been in the ICU. You can imagine that if you were in a near-death experience of being ventilated and in an ICU worrying whether you're going to live or not, you could also be having some issues with PTSD and maybe depression and anxiety related after that. So it's important to be aware of that in patients and be prepared to help to manage. Certainly general deconditioning and poor mobility afterwards are really where, physical therapy is going to help out quite a bit. So in March and April, an outpatient PT, there was a group of about 10 of us that tried to come up with, well, what's the clinical picture of what these patients are going to look like, and how are we going to manage them, and do we have a game plan for it? So we kind of made this decision tree, sort of COVID is the primary diagnosis, but what are all the impairments that we're going to see? What are the body systems involved, and how are we going to be prepared to treat those? And this is probably not an all-encompassing one, and one I should say right away that should be on here is voice and swallowing. But those are kind of the categories that we looked at that we tried to see what would be best practices to help to manage that. So starting with outcome measures, how are we going to measure this, and how are we going to see if this was a body system that was involved, and then how would we see if we were helping to progress the patient? So starting with cognition, we're recommending patients complete a BCAT, just simple cognitive examination, and probably a speech referral if you did notice problems with that. Just for overall function, just asking the patient if they had any difficulty with IADLs or ADLs, participation, and if you wanted to kind of get a better measurement of that, or numbers behind it, you could do a CATS or a Lawton scale. Balance wise, we kind of went back to what the neuro section had put out as our core outcome measures to measure balance with. So FGA, a 5-time sit to stand, and gait speed. And I also put in there just to make sure your screening of the vestibulo-ocular system is happening as well. So we do know that some cranial nerve impairments are happening, so making sure that their vestibular system is functioning well, and make sure their ocular system is functioning as it should be as well, because that will certainly have an effect on balance. Endurance, so we kind of went back and forth about this. So a 6-minute walk test, some patients maybe couldn't complete that, so maybe a 2-minute walk test. And if people are kind of beyond being able to do a 6-minute walk test, maybe a bulk protocol. So using the bulk protocol, you can come up with more specific recommendations of where that heart rate and exertion can get to, and then make very specific prescription for aerobic exercise from that. Strength, just doing your classic manual muscle testing. And then for a patient-reported outcome measure, we're hoping to have patients do a patient-specific functional scale. So really looking at what their goals are and what they want to get back to, and then kind of being able to score them based on that. And then again, making sure we're screening for patients' mental health. So PHQ-9 to test for depression, or an impact of event scale for PTSD. So we wanted to give some, slow down, make sure we're really covering systems. So if somebody had been in ICU, had been on a ventilator, making sure that those are the patients that we're really making sure we're really thoroughly checking their cognitive status. What are you having any difficulty with swallowing, going through that impact of event scale and PHQ-9 screening. So we had put together kind of an evaluation form to go through for some of these prompts. And these are the yellow flag questions that we put in there just to kind of give a heads up. Okay, this person might be somebody that maybe needs some further referrals and might need some closer following. I really think for the most part, people that were in the ICU or on a ventilator, probably if they needed follow-up therapy, ended up in a facility somewhere and then ended up, with referral that way. But it's not out of the realm of possibility that a patient could end up back at their PCP, then with a referral for outpatient PT. So just kind of a good thing to be aware of. So again, some more of those evaluation prompts, just going through, making sure, no difficulty bathing, dressing, doing the things they need to do at home. And if so, make sure we're referring to occupational therapy to give help for those things if you felt like it was outside of something that you would be able to perform as a physical therapist at a community clinic. Any difficulty with swallowing. So thin liquids, I put this picture of this lady drinking water because that's going to be the thing that probably people will have the first problem with. And you might not always realize it. And if you give the person a prompt, well, are you coughing a lot after you're swallowing water? They might say, oh, yeah, I am. So you'd be like, oh, well, maybe we should take a look at that. Any changes in voice, again, just again, a good referral to speech therapy just in case. So thanks to Amber Cunningham for putting together this breathing evaluation. So kind of just going through and looking at is the person on any oxygen to start with, which, you know, is going to be obvious when they walk in the door. But then again, what's the titration of it, and making sure we're asking those questions, because that's something you're going to want to wean down on. Are we using accessory breathing muscles, nasal flaring, subcostal retraction, those kinds of things. And then looking at capillary refill. So what's their perfusion like? And kind of going through this evaluation form to really look at what their quality of breathing is. I will say, in my experience of working with these patients, they were mostly referred in my clinic at 8th Avenue from acute rehab. And so they came with referrals for speech therapy and occupational therapy right away. And actually, our speech therapists really worked on breathing with the patients more than the PTs did, in this sort of more specific way, which has been really helpful. And then as far as SLPT outpatient algorithm, I put algorithm in quotes because we really just kind of went from, if somebody's severely impaired and they need more services, they're going to end up at our multidisciplinary clinics. And if it's not quite severe and there's not those other systems involved that require speech or occupational therapy, then keeping them at community clinics. So those screenings that we went through to make sure that we're triaging appropriately, we're looking at cognitive deficits, participation, and overall mental health. And again, if there's any sort of mental health impairments, notifying the PCP and referring to psych services as appropriate. So, you know, we all learn in physical therapy school that doing a thorough systems review is really important, and just can't stress it enough for these patients, because I think they're, you know, if you go on the CDC website or you Google it, the list of symptoms that you could possibly have from COVID is so long because there's so many body systems that could be involved. So if somebody could be like, oh, I'm a little bit dizzy, but, you know, that's not my primary concern. But you know, it might be that their vestibular system is involved, and you didn't even realize it till they didn't even realize it because they were kind of dealing more with breathing problems to start with. So it's really good to make sure that you're kind of given a really good overall picture of everything, even more so than usual. So around the end of June, the APTA put out a list of what their recommended outcome measures were for post-COVID patients. So taking a look at these, SLM scale for cognition, quality of life, PROMIS Global 10 and EQ 5D, strength, a medical research council sum score, which is basically manual muscle testing, and then it's scored. A short physical performance battery test, which we did have some back and forth about, but that one is a 5-time sit-to-stand, and a gait speed test, and then it's scored into a total score and then called a short physical performance battery test, and then endurance, a 2-minute step test. I personally have actually never formally scored any of these tests before, and I think that they're a little bit less common. And I think that a lot of the goals of these outcome measures are really geared towards doing research. So if you wanted to do research within the system or within your patient population, this would be a good way to make sure you're scoring these things. They're not at this point necessarily validated for post-COVID patients, but just like we were doing, kind of taking impairment systems and how we usually measure them. So my thought process on this is, you know, we're dealing with an unfamiliar diagnosis, so I'd rather stick with outcome measures that I'm more familiar with. As time goes on, if we see that, you know, this is a really good way to score them, we could always make that switch, but, you know, I'll leave that up to per clinician discretion. So along with those outcome measures, the APTA put together an algorithm. So kind of really starting with going through somebody's cognition levels and their quality of life levels, and then triaging from there. So if you look at the top, it's going through, you know, just plain, are their vitals stable? Are they able to understand directions, and kind of triaging from there, going through what their level of ability is, and then kind of going through manual muscle testing, a physical performance battery, and a 2-minute step test. If there's ceiling effects to any of these, it kind of go actually more towards the outcome measures that we had listed before. If they're not quite there yet, then the floor effect, then you're kind of downgrading and going over to this category and going to some different measures from there. Special considerations are over here on the side. Again, making sure that mostly this is a summary of making sure we're referring as appropriate for help for cardiovascular and pulmonary help as needed, mental health, pediatric population. I think they're coming with another algorithm for specific pediatric, and then neurology, making sure you're going through and doing the tests and measures that are recommended by the neuro section for the core functional outcome measures, if there's any neurologic involvement. So as an outpatient PT, I think the things that most of us, and myself definitely included, are least familiar with are doing physical therapy for cardiopulmonary patients. So I think that's the thing that people feel most uncomfortable with. So I wanted to kind of go through what the recommendations are as far as aerobic conditioning and strengthening for those patients. So for a pulmonary involved patient, the thing that's going to be first to keep in mind and the most limiting thing is going to be their perfusion and their oxygen saturation and their overall being out of breath. So for those patients, we're going to really look at aerobic conditioning recommendations based on their dyspnea scale. So dyspnea scale is a 0 to 10 scale. It's basically an RPE scale, but looking at their rate of how out of breath they are versus what their heart rate is. So typically how out of breath they are is going to more relate to where their oxygen perfusion is than what their heart rate is. Now, just like Lauren had mentioned, sometimes their level of dyspnea does not actually always correlate in these patients, in these COVID patients, with their oxygen saturation. So it's really important to be following what their PO2 is on a pulse ox. So I had a couple patients that their dyspnea scale, they're rated like maybe a 6. And go look at their PO2 and it's at 82. And I was like, oh my gosh, you better sit down. Really, so normally if you see a patient whose PO2 is at, pulse ox is at an 82, they're on the ground, they're not still walking. But that's kind of something that inpatient had noticed as well and kind of talked about to us before we had seen these patients. So it's kind of interesting. So it's really important to be monitoring vitals as well. But so these patients, what you're trying to do is kind of keep their rate of exertion or their dyspnea scale some between a 3 and a 5. So moderate to heavy, but not kind of going beyond that. And it's a good idea to monitor their heart rate and see where they are with that, but that's probably not going to be the limiting factor or how you're going to prescribe. As needed, using short intervals to kind of build up and then progress to a 30 to 45 minutes of continuing exercise. And again, best outcomes for a pulmonary patient are probably going to happen when they're using their weight-bearing muscles of their lower extremity versus doing a whole lot of arm exercises. All right, so for the non-pulmonary involved patients, so somebody that maybe is just general deconditioning, but they're having good oxygen perfusion, they're not out of breath, they're doing okay, then you can kind of look more at heart rate. So the general heart rate recommendations for conditioning between 40 and 70% of predicted heart rate max. And I have a little asterisk in here about it's important to keep patients in these more conservative ranges for 6 to 8 weeks in order to avoid coughing and forceful expulsion of droplets. That was, a couple of presentations that I listened to back in April and May had said that. And I actually had asked Dr. Masidi about this because I was like, well, some of these patients, they're going to start coughing the more they're exercising. She says, as long as everybody's wearing appropriate PPE, it should be okay. Meaning, so as long as the patient has a mask on, you have a mask on, everybody in the clinic has a mask on, it shouldn't be a concern. I know sometimes it's hard to keep on a mask when you are exercising at this kind of a rate. So just kind of things to keep in mind. It's just a review of what a 0 to 10 Borg scale is that you can also use with these non-pulmonary involved patients. I have in parentheses about not without a CVA. So if you have a non-pulmonary involved patient that had a CVA, We're actually in current recommendations looking for more like 65 to 85% of predicted heart rate max. So, you know, the more you can push them, the better. So strengthening recommendations. So we're looking at low resistance training at higher reps to start with until they get a little bit stronger and a little bit better able to tolerate exercise. Then we can kind of go to the more traditional 8 to 12 reps at 85% 1 rep max. And then at that point, you can kind of consider any inspiratory muscle training that you might feel is appropriate. So considering the fact that a lot of these patients are going to have balance difficulties, mobility difficulties, maybe have goals all over the map of what they want to get to, keeping these aerobic recommendations or strength training recommendations, it might be good to really combine that into something functional. So if you have somebody that really wants to get back to, you know, doing yoga and they need to get their balance better, you can kind of combine all sorts of things together. Stair climbing, lateral stepping, backwards walking, going outside on uneven surfaces. So I think usually if you're thinking about aerobic recommendations or pulmonary rehab or cardiac rehab, most of us kind of think treadmill, bike, but really get some functional exercise in and kind of work with the patient as you would you know, any other patient that you're treating for their balance or their gait or whatever else. And then we're just keeping track of their aerobic output while they're doing that. So it's kind of like a combined effort altogether. So, you know, getting back to improving their balance, if they just want to get better at walking with their walker or their cane, and you're doing gait training that way, you're keeping track. If somebody wants to get back to bowling like this lady, you can practice squats with a weighted ball. Certainly doing some stair climbing, or if patients want to get back to prancercising, get them up and prancercising. Monitoring vitals, super important. So before you start exercising, while they're exercising, after exercising, I kind of the PO2 being really important because it's not always that the person is going to be having reports of being as out of breath as what their oxygen saturation is reading, and we really want to keep that up over 90%. I put this picture of a polar heart rate monitor on there. I'm not getting any financial reimbursement for this, but they're really cool. So you can have continuous heart rate monitoring going, and it feeds back Bluetooth onto your phone. So you can, or your phone or your iPad, whichever one. They're about $90, and outpatient wise, you can order them through SME, through the monthly order if you write a comment in the comment box. But they're super nice to give some continuous heart rate monitoring, and you kind of keep looking at, is there, you know, RPE matching what their heart rate is, and are we, you know, staying where we should? And then a blood pressure cuff, because we monitor blood pressure for sure. So this is just a quick review of contraindications to exercise and also reasons to suspend or stop exercise. So again, we want to keep oxygen saturations over 90%, so it's you're definitely keeping track of that, and also a good review of what vitals should be and what changes might warrant us stopping for exercise. And I'm just going to kind of outline just another caveat on the bottom here. Under the other is a painful calf suggestive of DVT. It's really important for these patients to make sure you're screening for DVTs in them, because that's something that they are at risk for. So just, you know, make sure you're doing a good screen when you see these patients. Another quick review of medications affecting response to exercise, just to kind of keep that in mind, because a lot of these things might be something that somebody is on. And breathing exercise. So quick talk about diaphragmatic breathing. Just making sure that the patient isn't contracting their abdominal muscles, and to move that book, and that their air expansion is really happening through their lungs. This is a quick exercise that you can do with patients. Again, I would say I don't have a ton of personal experience with this, so I don't feel very comfortable talking about it, because most of our speech therapists really did the breathing exercises with patients, and even some co-treats together with the exercise and breathing at the same time, which isn't a bad idea. And something to kind of keep in mind if you feel like, you know, you're feeling like you're maybe not comfortable with this, it's always something you could refer to speech therapy, and if they were really involved with difficulty breathing. All right, so back to that case study that Lauren had started. So let's say that patient ended up, let's pretend that cerebellar CVA was a little bit bigger than what she had talked about, And they ended up in acute rehab, and that's where she did a 3-week stay in acute rehab. Got home yesterday and now referred to you as an outpatient PT. So these are the categories of things that you want to measure, and those are the measurements, those are the outcome measures that you chose to do. So these are your outcomes. You notice a moderate impairment with the BCAT. Her PSFS was a 19 out of 40. Manual muscle testing, you notice weakness throughout the upper and lower extremity, grace on the left side with ataxia and dysmetria present. So cerebellar CVA. Balance is a 13 out of 30, so she's definitely at a high fall risk. Endurance, 6-minute walk test, only made it 450 feet, which is pretty low. And her PO2 did drop to 89, and she was a 7 out of 10 on the dyspnea scale. So endurance is pretty poor. And function, it definitely needs some assist. And I threw in kind of, because the short physical performance battery is what the APTA recommended with the individual 5 times sit to stand and gait speed. So 26 seconds for a 5 times sit to stand and 0.5 meter per second for gait speed. So this person's definitely at fall risk and not community mobility at this point. Her yellow flag questions, was she in the ICU? Yes. Was she on a ventilator? Yes. So we did just a screen for depression, which she scored an 11 on. So that would be something to probably talk to the PCP about within that category. Definitely having some difficulty. She needs help for doing any sort of bathing and dressing, and she's completely dependent for doing any cooking, cleaning, laundry, those kinds of things. Having some difficulty with swallowing and some changes in voice. So most likely, having come from an outpatient or from an inpatient acute rehab, she probably would have come with scripts for PT, OT, and speech. But for the sake of argument, you decided in this point that, okay, I went through all these screenings and this patient should probably be getting multidisciplinary services. Taking a closer look at how she answered her patient-specific functional scale. So she wants to be able to walk independently without a cane at home, and she wants to be able to walk through the grocery store independently. She wants to be able to cook turkey dinner for Thanksgiving by herself, and she wants to go to her weekly bingo game. So she scored a 6 for bingo, and without using a cane at home. So she's okay for some short distance walking, but when she has to walk through a grocery store on her own and like do some functional picking up turkeys and turning around in the kitchen and carrying things, she's a little bit less confident. So kind of correlates well with the impairments that we had screened for and saw. So my plan of care, I'm probably going to want to see her 3 times a week to start with, at least for the first month, and then maybe taper down to twice a week once we can know that she can safely exercise and do her home exercise program at home. So that 3 times a week, we really want to get her going 3 times a week, doing her aerobic exercise program and really working on her overall endurance. So we'll start at 3 times a week till we know that she can monitor her vitals safely on her own while she's exercising and do that independently. Again, referrals to speech and occupational therapy, and mental health, we'll have a discussion with her PCP. So my goals, or I want her to be on my long-term goals, I want her 40-40 on her PSFS. I want her walking throughout her home without a cane consistently, and be able to do her home exercise program and progress herself in the end. Shorter term goals, I want her to be able to complete that 6-minute walk test, keeping her oxygen saturation over 92% and be able to walk a little bit longer. So normal for her age is still probably more like 12 or 1,300 feet, but I'm looking for 150 foot improvement as an MCID with a single point cane still. Patient will score 18 out of 30 on FGA within 4 weeks. So we're getting closer to the non-fall risk category, but we're not quite there yet, but getting better, and hopefully getting independent within 4 weeks. So maybe at that point we can drop down to 2 times a week. So what does a therapy session look like at this point? So again, we're kind of going to start out with some interval training because she couldn't tolerate 6 minutes of walking. So we'll probably start with maybe a 4-minute interval of activity and then a 2-minute recovery. So I've got her at a 5-minute warm up, and I'm looking at her dyspnea scale because she did desaturate on day 1. So I'm trying to keep her kind of at a lower output to start up just for a warm up. So maybe out of 1 or 2, real nice and gentle on a new step. And then our first interval of exercise, we'll start with step ups. Then we'll do some side stepping, some high knee marching, sit to stand. So kind of going through some balance activities, but also functional mobility and ambulation. Sit to stands, working on her transfers, making sure she's safe to get up and down out of her chair. And her 5-time sit to stand wasn't that great to start with. And then some plain old gait training, walking without a cane for 4 minutes at 2 different intervals. And then practicing some backwards walking, again, just for some balance and practice of walking and endurance. And then ending up with some easy heel and toe raises, standing hip abduction, just to get a little bit of strengthening in gently and just for a cool down. So alternating between a standing break and seated breaks, and that can always vary as we can, but kind of keeping track of making sure we're not sitting for more than 2 minutes and kind of getting her back up again. So that kind of gets us through 45, 50 minutes worth of a session, and with any bumps in the road in between. So that's kind of a sample of how we've been going through sessions with these post-COVID patients in general. So major take-homes, like I had said a couple times before, make sure we're prepared for multi-system involvement and you're doing a thorough systems review to make sure we're looking at every possibility of what could be preventing this patient from being in their full function, and we're getting any referrals in that are necessary. If anybody's familiar with The Office, Dwight's ready for anything, so that's kind of the way we should be too. And if anybody packs for vacation like me, they've got 35 outfits, even though they only need 4, but that's kind of the way to be with this. So make sure you're ready for 35 different diagnoses, even though you might only see 4. But that's the way, we're going to have to handle things in a multi-system way. And I just want to say a special thanks to everybody that helped in March with putting together these outcome measures and getting the outpatient PT prepared for seeing patients. It was hugely helpful, and I think for those patients that we did end up seeing and might soon be seeing again, it was really helpful for everybody. All right, and there's our references. Thanks.